Hi, this is Dr. Scott Munsterman here with Dr. Arieh Grober, and we're going to have a good conversation about traction. And in particular, we want to talk about the evidence-based approach to lumbar and cervical radiculopathy. And I'm just so pleased to have Dr. Grober with us. Dr. Grober is an independent advisor for the Israeli Medicare Insurance. He's a member of the American Back Society, the Israeli Spine Association, the Israeli Pediatric Orthopedic Society, World Chiropractic Federation, and since 2000 has been registered in the international who's who of medicine and healthcare. In 1999, Dr. Grober invented and registered the patent on the popular Cervical 2000 cervical portable decompression device, and that's a medical device that is sold worldwide. He also published research about spinal disorders and techniques for treatment on traction on the move. And we're going to learn a little bit more about that later on in the presentation. And that specialty has been focused, his clinical specialty has been focused over the years on disc herniation and other back and neck disorders such as scoliosis. He's a graduate of the Technion Israeli Institute of Technology. I'm saying all these words wrong, Dr. Grober, and I apologize. The Rappaport Faculty of Medicine. He did postgraduate training in Munster, Germany on innovative orthopedic techniques, as well as an intensive program on fetal ultrasound techniques, among all things. And so, Dr. Grober, thanks for being with us. As we begin this discussion about traction, I know that in our previous discussions, it really does seem to, for the lion's share of time, focus on lumbar and cervical radiculopathy. And of course, we understand radiculopathy by definition to be pain that radiates down the legs or down the arms, into the extremities. Patients many times that see us for this particular type of disorder or symptom complaint will describe it as an electric sensation, as a burning sensation, as sharp. And clinically, we understand that the most common underlying cause of radiculopathy is irritation of the nerve root, which can occur at any point along the nerve itself, and most often is the result of compressive forces. And so that compressive force, as we know, could occur within the thecal sac as the nerve exits the thecal sac into the lateral recess space. And we also understand that the nerve root traverses that neural foramina. And even after the nerve root has exited the foramina, it could be related to disc bulging or herniation or facet or ligamentous hypertrophy, as we see with osteoarthritic types of conditions, or maybe some other types of space occupying lesions that could be involved. And we also know that the most common level of nerve root compression in the cervical spine is the C7 followed by C6 levels. And compression of C5 and C8 roots are less frequent. Lumbar intervertebral disc herniations typically occur most commonly at the L4-5 level, affecting the L5 nerve root about 50% of the time, and at L5-S1, affecting the S1 nerve root 46.3% of the time. And you know, of course, the most common compression of that fifth lumbar nerve root with the first sacral nerve roots is essentially the lion's share of what we see for radiculopathy in the lower extremities, in the lower spine. And we know that there's quite an impact, both a sensory impact, a pain impact for the patient to experience, a motor impact, reflex changes that we pick up. And so as we talk about lumbar and cervical radiculopathy, we know the most common regions. We understand the ramifications, but when it boils down to it, how do we clinically assess these types of conditions? And so, Dr. Grober, we want to talk a bit about orthopedic testing and lumbar spine testing. And in your practice as an orthopedic surgeon, give us a little bit of a feel for how you approach evaluating a patient with, let's say, right leg pain.
Okay, first we're talking about lumbar spine. So first I have to ask him, you know, what you feel, whether you have pain, if you have radiation, which leg, outside of the leg, if it goes down to the feet, and if you have numbness or all this kind. So like this, I will see that, and then I make a test, SLR and pressure on it, and feeling how the power of his muscle, and then I have know a little bit. I know that you have a lumbar, so L4, L5, L4, L5S1, and sometimes I can begin to treat him before I have even MRI or CAT scan, because I know the problem. As you say before, that 80% of the people lumbar problem is 80% of the people is L4, L5, L5S1. So I can begin to make treatment and traction what we're doing without MRI or CAT scan. Some patient we begin to treat him. So when he going to make the MRI or CAT scan, it take 1 week, 2 weeks. Sometimes we feel better before I get the MRI. And I know how to make it on the right side, on the left side, that I make pressure and traction and also horizontal forces. And he began to walking in the clinic, or usually we put him on a treadmill. Because on the treadmill we saw that we have better result. We're talking about around 20% have better result when he's walking. That's why we called it the traction on move. And usually we used to begin with everyday traction for half an hour. And then I will usually test him again or look again after 3-4 weeks a day. And then it depends on the clinic, because the clinic is very important for me and for the patient. Then I know how to continue with the patient another week, or then make it every 2 days or twice a week. It depends of the feeling of the patient.
Yeah, very good. And so I love that. I love the scenario that you just created in terms of the patient coming in and the questions that you ask, the assessment process, measuring the pain side of it, and then getting a good feel from the orthopedic testing side of it. And then as you do your conservative treatment, because you as an orthopedic surgeon today have devoted your life to the conservative management, which definitely we applaud. And your reevaluation then being at that 3rd to 4th week of care, and you're going back through and you're following up then with your orthopedic testing to determine if there's been improvement?
Yes.
Yes. And so as we take a look at the orthopedic tests, as you mentioned, we've got Kemp's in a seated position, bringing the patient into extension and rotation, and it can be done in the standing position as well, and closing down that foramen to see if we do or can elicit that nerve root compression. You talked about the straight leg raise, the SLR, being the nerve retention test, and that's been a valuable orthopedic test. Would you say, Dr. Grober?
Yeah, of course. Very important.
And then, of course, the well leg raise, the braggarts were certainly.
Well, it depends the degree of the SLR.
So talk to us about that. What's your experience been with the degree of SLR, the pain production, and the either response to care, or what do you clinically learn from that based on your experience and what you know today?
The SLR is very important, because some patients, when in the beginning, they have SLR 10% or 10 degree or 20 degree, and after a week, I see it become a 40 degree, 50 degree, and this means that pressure on the nerve root become lower and lower. It's very important. Also, I ask the patient about the pain. It's also important, not only the test. Because also the sensation and the power of the muscle is also very important. Usually we're looking of the EHL, the extensor hallucis longus. Usually the feel it, the power of the extensor hallucis longus, very important for me.
Yeah, the motor strength and all of that. Very good. And then we've got our, of course, being able to do the best we can to detect space-occupying lesions, whether it's discal or other, the Valsalva, Bechterews, and just that combination of Bechterew, Braggart, and Valsalva combined together, closing down that space, and if there is a space-occupying lesion, that can be helpful at identifying that is occurring at that.
Yeah, if the Valsalva is positive, that I used to tell him that it means that the disc is make a pressure.
Exactly. So we talked a bit about the lumbar spine, Dr. Grober. Now let's shift gears and let's talk about the patient that comes in with upper extremity radiculopathy. Talk to us a little bit about how you assess that patient and what do you do when that patient comes in?
Well, first I look on the patient if he have a range of motion, full range of motion, of some also if you have torticollis, not torticollis, and I ask him if he have a radiation, and it's very important the radiation goes to the shoulder, to the elbow, or to the finger. That I can know, talking about C5, C6, or C7, well, I know how to manage it. And also I try to ask him the power of his biceps, the triceps, and all the finger, then the sensation, all the same orthopedic testing. Very simple, but very important.
Yeah, exactly. And so as we take a look at the best cluster, and this reference has been very valuable to many clinicians to understand that there are a few tests that have served us well at helping us determine what the positive likelihood is of nerve root compression in the cervical spine. And of course, you mentioned restricted cervical range of motion. We have the upper limb tension test and distraction and Sperling's maneuver. And then, of course, history questions, as you've talked about, and talking to the patient and getting their history, how, where does that arm pain go? And for those clinicians that are not familiar with the use of likelihood ratios, there's a great reference here to bone up on and to learn more about that. And it provides a good, reliable predictive factor when you have 3 or more, especially positive findings in this particular cluster, giving a positive likelihood ratio of 6.1, which tells us that we're pretty darn sure we've got a nerve root compression situation going on. And some of those orthopedic tests that are within that cluster, of course, Sperling's compression test, with the patient in the seated position and neutral cervical posture. The patient side flexes head to the side of the referred symptoms, while the clinician or examiner applies a combined compression and side flexion force in the direction of side flexion, reproducing radicular pain. That would be the positive nature of the test, indicating nerve root involvement in the arm. We have very common the cervical distraction maneuver, which is reduction of the radiating pain. And then, of course, we have the positive upper limb tension test, which also places that upper extremity in a position where it applies tension to the nerve root, with thereby reproducing that radicular pain and indicating nerve root involvement into the arm. And then as we mentioned, another component to those exam findings within that cluster is a decrease in cervical spine range of motion. And I thought it was interesting, Dr. Grober, that was one of the first things you talked about in your assessment with your clinical experience.
It's very important, the range of motion.
Yes. And then as we move on to the neurological evaluation, I know that you've touched on how important the motor evaluation is, the motor power. You've touched on sensation. Talk to us a little bit more about cervical spine neurological evaluation, lumbar spine neurological evaluation.
Well, the neurologic evaluation, we're talking about the sensation, very important, the power, very important, the power. The reflex also we test, but I don't think it's very important, but we also test the reflex because, you have all the things, all the neurologic things, because we want to see after 1 week or after 10 days, we know we want to see what is changed. It become better, it become worse. Not only what the patient said. Sometimes the patient said, I feel more pain, but the neurologic, it's look better. And sometimes it's the opposite. But it's not always go together. It's very important to make the evaluation, also ask the patient how they feel, then to make all the tests.
Yeah, and that's a great point, Dr. Grober. So many times as clinicians, we have to it's important to us how the patient feels, right? Hands down. It is important to us. However,
it's very important because also the patient feel that you interest. You want to know. You want to know, and you feel good.
Yeah, exactly. But as you pointed out quite well, it's important for us to focus on those clinical objective findings, and okay, what's changed, and being objective in all sense of the word to, okay, here's what I feel is different, or here's how this test now is not near as positive or not nearly generating the pain, or, that SLR went from 10 degrees, like you said, to 40, and the patient may be still having pain, but we see objective change and we see improvement. And of course, symptoms typically follow at some point once we have good objective change happening. And so great point on keeping our frame of reference as to how do we judge progress towards the condition. And as we talk about that, go ahead, Dr. Grober.
Just a moment. Also, it's very important to ask the patient about the medicine you take. Because some people began when they come to me because they began to get the opiate. And it's very important. I try to take it off. I want to know, and I very did that after 3-4 sessions, he said, I finished with the opiate. I took only some kind of painkiller, something. It's also very important to know all these things.
Yes, very good. So, Dr. Grober,
I don't like the opiate. It's another thing. But, another things. Don't like it.
Yes, very good. So, Dr. Grober, with your experience that you've had, what would you say causes the disc to bulge, herniate, and degenerate?
What about?
Yeah, what in your opinion, what causes the disc to bulge, herniate, or degenerate? What are some of the causes?
Usually, it's the people that used to sit a lot, not working hard. People that are working hard, they don't have a lot of problems with the back. Usually all the high-tech, all the people from high-techs and sitting a lot or driving a lot, they suffer a lot from the back pain. And, it's catching in the middle when they running to make a good business, and then suddenly they don't understand where they come from. But usually when you sit a lot, sometimes, of course, it happens when you play something, you make a rotation or you bending, simple things. I used to tell I have a week ago a secretary that she don't make exercise, she don't nothing. She just sit every day 6 hours at the computer, and she don't know how it happened. She get the herniated disc huge from nothing. I said it's like this. That's it. You don't need to make nothing.
Yeah, you are so spot on, because as you pointed out, the traditional view, what we used to think was that, it's those people that are doing a lot of the lifting. they have a lot of stuff going on at work and it just wore that disc out, and that if we wanted to prevent that degeneration or that disc injury, then we'd have to reduce the spinal loading, while they're at work. But as you pointed out, physical loading on the disc actually enhances the disc health. It doesn't harm it. And having that mobility and that, like you described, getting up and moving around and actually being active. And as this study demonstrated, higher levels of physical loading, those who were heavier, stronger, had a slower rate of disc degeneration in terms of signal loss on MRI. And those subjects who had smaller discs and greater compression per unit area also had a slower rate of signal loss as well. And so I just thought that was interesting. The old way that we used to think about things, or what would seem to make sense, really don't.
Yeah, sometimes people say to me, I'm working in the garden. I don't lift heavy. I told him, you don't need to lift heavy. It's what you're doing. You do some small moving. That's enough. You don't need that to take something heavy.
Right. And as the study also pointed out, flexibility and stretching and strengthening and, proprioceptive gait training type programs, weight loss programs, proper lifting, anything that would improve postural biomechanics is a good thing. And that's what we've learned.
Talking about mechanical problem, not this. This is a mechanical problem.
Exactly. And so one thing we know, and we see this a lot on plain film x-rays, right, where we'll have a plain film radiograph. Let's say it's an AP and a lateral lumbar. And one of the things we look for would be the health of the disc. And if a disc is not healthy, what do we see? We see disc height loss. And talk to us a little bit about that.
Okay, look, first, I used to say to the patient, I don't treat the picture, I treat the patient. Sometimes you saw the higher of the disc is become very narrowing, but the bulging disc is above or below. It's not only what you see, the higher is the problem. The higher the problem of the space between the discs, sometimes, it goes years ago, but the disc is not usually have to be the same when the higher it becomes less. Not usually, not always is like this.
Right. So you've been involved with conservative treatment of disc-related conditions, and of course this study in particular talked a bit about surgery for cervical radiculopathy or myelopathy, and that they came out and stated that there is a low quality evidence that surgery may provide pain relief faster than more conservative care, and that there was little or no difference in the long term. And the same with patients with mild myelopathy. They were better shortly after surgery, but then when they went on the long term, there was little or no difference between conservative care versus surgical care.
Well, because, we used to see to make an operation in the cervical or lumbar region, I tried to make everything not to go to operation. Because when you're operation, you know how you get in, you don't know how you get out. And the doctor can promise you a lot of things, but I saw so many problems after operation. Sometimes the problem began after 1 week, sometimes after some months, sometimes 1 and 2 years later. You used to say that if the operation succeeds, it means that you pass 5 years and no problem.
Well, and to your point, I mean, this particular study, as they tracked those patients, they evaluated over 500 patients with herniated lumbar discs. They compared surgical and non-surgical groups. And to your point, that within 2 years, they improved substantially over a 2-year period with improvements consistent in favor of surgery for all periods, but that were small and not statistically significant. And so at the end of 2 years, if you can make it 2 years, you're going to be at about the same point as somebody that has surgery. But then to your point, moving from 2 to 5, who's going to fare better? Somebody who had an operation on their back or somebody that didn't?
But operation is you take a lot of risk.
Right.
Take a lot of risk. Nobody can promise you an operation that you will succeed for 100%. Nobody can promise you. You have a problem with a lot of things. I saw so many. We treat a lot of patients after operation. So if they don't have a fixation, if they're not. We wait 3 months, then we can treat it. And we have a lot of success with traction.
Yeah, so let's talk about that, because the conservative approach has been traction, right? I mean, that's been the conservative response to disc syndromes or disc conditions. And let's take a little bit of a look at what the research has said over the years about that, because it's been somewhat mixed. I mean, if you go back, and of course, this was a study that was done back in, let's see here, 2008, and it was a Cochrane review that they found that in their review, there was no evidence from random control trials with a low potential for bias that clearly supports or refutes the use of either continuous or intermittent traction for individuals with chronic neck disorders. There was another one that talked about, that they didn't feel there was no more effective treating low back pain with traction versus sham. And to date, in this particular study, there is no accurate description of the mechanism of relief provided by cervical traction. And so there's been some question as to does traction really work? And then what we found was just some interesting dialogue and discussion about why has there been this inconsistency in the therapeutic value of traction. And as we cited, evidence-based guidelines and those systematic reviews generally have not supported the use of traction for patients with low back pain because of, guess what, the lack of high quality of studies, patient samples, and lack of power of the traction itself. And so, but despite all that evidence, what do? We use traction, and it ranges from anywhere from 40 to 76% of us clinicians and therapists use it, in addition to combination of other types of treatments. And so as you begin to take a look at well-designed studies that have taken a hard look at traction, you find a completely different story. And so, Dr. Grober, as we think about the studies that are beginning to come out and have come out over the last few years in particular, what are the things that have stood out the most to you in regards to what we've learned about traction?
Well, why the traction is so effective. We saw it with the patient, because the problem I told you before, the problem is a mechanical problem. So we make a traction. We don't only make a traction. We tell him to move, to make exercise, to treadmill, and motion is very important, because we know when the motion, so the area when the disc is make a pressure on the nerve root. When you make a movement, more oxygen comes to the nerve damage, and he feel better. We saw the patient during the traction and after the traction. You saw the difference, and this is important. Important is the clinic.
Yeah, and so to your point, exactly, what we're learning now from various studies is that there's significant change in the musculature during traction. That's been proven.
During traction and moving.
Exactly.
Very important.
And then we do see differences in terms of overall pain, as you talked about, with the visual analog scale, increase in their functional mobility, specifically, whether it's lumbar or cervical traction. Again, another study on the effect on muscular activity and traction. And then we've got this study on cervical traction, and it talks a bit about how the separation of the vertebral bodies, movement of facet joints, expansion of the foramen, and stretching of soft tissues, and the impact that has mechanically, as you've cited, already, with patients with cervical radiculopathy.
Also, a patient with a facet joint in the cervical problem, more older patients that they have no range of motion, and you make a traction, open a little bit the facet joint, and the range of motion is still so different.
Right. And so another study, another well-designed study, again, proving the pain side of it, proving the function side of it, axial distraction. This study actually talked a bit about of the motion segment and how that changes the nucleus pulposus, and how it can change the dynamics within the disc itself, and those posterior annulus fibers that surround that nucleus, and decreasing that mechanical pressure, and enabling that to make changes with the overall dynamics and pressure against the nerve root. So we've got many different studies now that prove beyond a doubt that traction is valuable, and that it does help reduce that discal pressure. And of course, one of my favorite of these studies actually was this study here, where, and we'll get into this here in just a minute, where it's determined what type of power you needed in your traction, but then also in taking MR imaging during the tractioning, as well as afterwards, and being able to see that actual reduction of the disc being performed. And this, we have an active link here that doctors can go ahead and click on that. It's publicly available. I would highly recommend that all the clinicians that are listening to this presentation take a look and read that study, because it certainly demonstrates beyond a doubt the types of changes that can occur with the right type of traction. And I think that's the conversation we will get into here in just a few minutes, Dr. Grober. But as you look at this study and you see the MR changes, the before and after changes, and of course the elongation effect that occurs before traction, 30 minutes after traction has occurred, and just how that disc reduction ratio occurs. Is this consistent with what you've experienced in your practice?
Of course. And I say it again, the important is what the patient feels. That's the main point. How the patient feel, he go back to his work, he stopped to take medicine, the life is changed for him, he began to walking, he began to make exercise, he changed I usually change his life. It says, you make a twist to his brain. Sometimes people don't understand it. They feel better.
Right. And of course, with that change in how the patient feels, we certainly see changes in our objective findings. And so why traction? Well, as I think we all understand clinically, that we certainly want that vertical elongation. We want that reduction of pressure inside the disc. We want...
Yeah, because when you make a traction or elongation, you make a negative pressure in the space between the vertebrae and the disc. So you see it on the right side, you see on the picture. So they make pulling in oxygen, nutrition, and all these things. And you see it also, you can see it in X-ray when you make during the traction.
Exactly, exactly. And so this is just a bit of a summation of the research we kind of clipped through rather quickly there. But what we learned about looking at traction and looking at the well-designed studies, they all considered the type of traction. They considered the duration. They considered the position that the patient was in. They considered the frequency and they considered force. And they seem to be the key variables or important factors. So for instance, does the traction create maximum vertical elongation? Is the traction applied for at least 30 minutes? That was a key factor in the most recent study that we just reviewed.
Yeah.
Has the weight of the individual and weight of the traction force applied within a therapeutically effective range? And is the patient in a posture that is conducive to a neutral lordotic spine position during traction? Because there was a difference in the literature as to how that patient's position was as to the impact, and it certainly presented as a variable in terms of the patient's response. And as you think about these different parameters, and we began our discussion about traction, initially with, there's mixed response. Does it work or not work? Well, guess what? It wasn't designed very well in the approach of how it was analyzed. And when you think about these, 5 factors, they all play a role in how you're going to get a good response. And so as we think about traction and we think about the type, the duration, the frequency, the force, and the patient's position, the next conversation we need to have, Dr. Grober, really hinges on the advantages and disadvantages of common traction devices. And so let's talk a little bit about some of the most common ones that we have that maybe we as clinicians have been guilty of using and maybe not using. So for instance, weighted cervical decompression. Talk to us a little bit about this type of traction unit.
Okay, this traction, it's stable. You can't hear in this traction. You can make if you need more on the right side, on the left side. You can't make it because most of the people that the problem, the disc is usually bulging for the right end, to the left end, so I can play with it. With this, you can't do nothing. Also, you can't make exercise during the traction. It's fixed, and you can't move, and it's not make traction because I knew these things. I saw it.
No, that's exactly right. And so it's very limited, isn't it? It's very limited.
Also, the patient after 10 minutes, he can't suffer it anymore. Make a problem on his mandibular joint, temporomandibular joint. Make a lot of pressure this track.
Right, so it's not comfortable, and of course, yes. So it's very limited, but as we think about it, I've used these in practice just because I didn't have anything else to really provide for the patient in terms of traction. And then as time has went on, we've seen some more sophisticated types of traction units. And of course, spinal decompression tables over the last 4 or 5 years have become somewhat popular. But there's some give and take on those as well. I mean, between the space that's occupied in the clinic, again, we're applying only applies vertical traction, and the patient is supine and immobile, and so it doesn't provide for the best posture, that lordotic posture, and of course there is a cost factor with it. This particular study that we pulled, and that link will bring you right to it, the summary basically states that there is only limited evidence available to warrant the routine use of non-surgical spinal decompression, particularly when many other well-investigated, less expensive alternatives are available. So it's not saying that it doesn't help, but it's saying that, for the money and the space and for what it does, there may be some other alternatives that might be more helpful. And so
Yeah,
one of
but
the things,
you can treat one patient on this FICC. Then you have to wait. All the patients have to wait. Then you don't the friction of the bed not making up. I'm not sure because I saw a lot of patients with the FICC that don't help in the truck.
sure,
But a lot of friction power that you have
right,
to calculate.
right. And so when the friction power, I mean, that certainly reduces your ability to elongate that, and based on the weight and the pressure and all that you're able to use to the power to distract that area.
And you make only we make vertical pressure on horizontal pressure, and here you can't make the horizontal pressure.
Right. So there's advantages and disadvantages, right? And Dr. Grober, I know that you and your group has been able to put together a comparison table, somewhat of lots of different types of traction devices, and some of the factors that we found and that we learned in the literature to be important, such as the mobility and being able to have that 3D compression, if you will.
Yeah.
Talk to us a little bit about the different types of devices and just what are limitations or pros and cons.
Okay, you see on the blue, you see the difference between all the kind of the cervical traction. Usually, most of the traction, you lie down on the floor or I don't know where. You can't move, you can't do nothing, and you don't get the really traction when you make it. You feel some traction on you, but it's very uncomfortable to make with all this kind.
Right. And as we look at the cervical spine, which we see in front of us right now, and then as we look at the lumbar spine, again, mobility being a big part of it, the patient's posture.
It's very important. The mobility is very important. And the 3D traction is also very important because I can play on the right side, the left side, the vertical, horizontal. I can put exactly on the level of the disc problem. All others, they make a traction to the body, to the spine, to all the spine. They don't make particular to the point. For the point, the disc problem, the level exactly. I can reach the disc on the level.
So let's talk a bit about that. And this is a new concept for many clinicians, is to be able to have the ability to have traction applied specifically to a segment, motor unit, discal, unit, and to create and to have motion as a part of that treatment process. And as we think about this, Dr. Grober, why is motion so important when applying traction?
Motion is very important to the spine, to the circulation, to the patient. The patient feel more comfortable. He don't think on his pain. He's moving, he make exercise, and he feel free. He feel free when he makes the traction.
Well, and
he makes exercise. We make a lot of exercise during the traction. It's very important also, some of the people, the back pain is also, you have to talk to his brain that he will understand, that he will not think all the time. When he lies down, he can't move, he feels uncomfortable, the traction is not enough. I know some people told me, they make me traction, I don't feel traction. I don't know what they're doing, but I don't feel traction. And the important is the exercise that you can do during the traction.
Well, and like our earlier conversation about postural loading, and the old view that, if we're moving around too much, we're wearing things out. Well, no, that's not the case, right? And so when we have a disc that's unhealthy, certainly that vertical elongation and the best posture and all that, but then introducing the motion, as you've talked about, imbibing fluid back into that disc, allowing for the normal dynamics to begin to occur again within the disc. And of course, the patient experiencing some relief and some movement and some confidence that they can have to be able to move forward and feel like their condition is showing some recovery.
Also, we're talking blood circulation. It's very important to the area. The oxygen, it's very important, and you get it only when you move, when you make exercise during instruction, and when you're walking or all these things. Very important to the area.
So we're going to talk a little bit about this, because this is something that, again, it's a new concept for many clinicians that you can have traction on the move, and of course it's been based on a lot of the research, and we covered some of it already, just the concepts behind some of this. But as we think about this type of decompression and the ability to incorporate active rehab during the traction process, talk to us a bit about the types of rehab that you find is to be very beneficial during the traction treatment itself.
Well, you see in the picture, what you make exercise, you're walking, you make a lot of things during the traction. That is very important to the patient, to the spine, to the muscle, to the blood circulation, all the things together. You're not sure which is very important, but everything together is very important. You see the difference between when you make a traction, when you lie down, when you make the traction, when you make moving. It's so different. I heard the people say it's something changed in the body. Sometimes you don't always know what's changed, but the blood, the circulation, the muscles, when you move, because most of the patient, when they have pain, they have a contraction of the muscle. When they move, and the muscle make a lot of pain, so they make a release, so they feel better. It's very important.
Right. So it's not only just mechanically reducing that negative pressure within the disc, right? It actually is about rehabbing everything around it and doing it all kind of at the same time. And that's what you're telling us, is that the impact of that combination creates a very powerful combination in terms of recovery. And the other thing too, Dr. Grober, talk to us about, we talked a bit about the amount of weight that's able to be applied. What you've found is that 50% of the body weight of the patient can.
This is the best power that you can get the best result if you can arrive to something around 50% of the body weight. And you can't get it from others, no other traction you can get it.
And of course, you've had the experience of treating over 10,000 just low back pain, and with radiculopathy included, I'm sure, within that cohort. And you've got your statistics here. When you say that there's been a success rate of over 85%, talk to us a bit about what that means.
80. We're talking about the 80-85% success. It's been no medicine, no pain. They have free of can walking, that can make exercise. They go back to gym. Best, better life. That's it. And usually we call him back to make, to conservative, to make one month, and no recurrence. Sometimes they have recurrence for 1 year or 2 years, but it's normal, the people is working. He's sitting a lot. We try to learn him not to sit a lot, but the recurrence is very low. And if it's a recurrence, it's it's in the small, pain. It's not a huge pain.
So the part of the success of this obviously is, and you've mentioned this a couple of times already, the three-dimensional impact of the traction device.
Yeah.
Talk to us a little bit more about that.
You see the three dimension. You see one of the traction force, and the result force is parallel to the lumbar spine. And that, I think, one of the important and why it's very successful. The horizontal force, the traction force, and the result. And you saw the black one, you see it's parallel, the result is parallel to the spine. And I think it's one of the reasons why it's very successful.
Well, and as we've learned in the research, that is certainly one of the important factors is that body position, or that position that the spine is in, and between the ambulatory, upright positioning of the body and the human frame. I mean, that naturally will cause our spine to be in cervical and lumbar in that lordotic position, but then the direction that the traction unit itself can apply helps create that extra added dimension or dynamic of a dimension of a vector of force, correct?
Yeah.
So let's talk a little bit about some of the statistics that you've had. Walk us through some of these before and after MRIs.
Okay, you see the MRI before the traction, and you see the different after the traction. We saw the disc has become half of is bulging or extruded disc. And you see the difference. Sometimes the disc is just disappear. If you make an MRI after 6 months or 1 year, the disc is really disappear. And because there's a lot. Some people said, okay, if you don't make anything, also it can disappear. But we saw it very quickly to the other things. So, and the important also, we arrive also, you don't treat the picture, you treat the patient. Because the important thing is how the patient feels. Here you see the traction, you see the X-ray. So you saw the difference is, we're talking about the 3 millimeter difference. It's a lot. It's a lot of the traction, during the traction. So you make a traction, then you take it off, then you come day after, you make again traction, and after 5, 6 traction, it will stay in the 15 millimeter. Because it make a negative pressure enter the disc. And here you saw a patient before the traction and after the traction, 3 months. You saw the big difference on the before the traction. So a huge disc go posterior, L5S1, and if you saw 3 months later, it's really you saw some bulging not more than a small bulging. Sometimes it's normal, everybody has a bulging disc, even if you not have a pain. Oh, here you see it closer. It's a different huge disc, and after it just disappear or become very, very small. Very, very small. It means that I hope you have a lot less pain. Also here, you saw on the left side, the extruded disc, and after you see the foramen is open. The foramen is open after the traction. And I'm sure the nerve root is free of pressure.
So that's just some examples. That's just a few examples, right, of the impact of
it's
the
from my
traction.
clinic. I have a lot of X-ray like this.
Good. Well, I tell you what, we're at the end of our time here, Dr. Grober, and as we think back to traction in general, it's come a long ways, hasn't it? I mean, in terms of the, what the literature has said, and maybe there's been times because it was misunderstood as to how to make it the most effective for disc conditions. We've learned a lot, and we've learned about the type of traction. We've learned about the frequency, the weight, the amount of time that it should be in, the patient's posture and their body. What are those factors? All of those factors. What do they have to do with the progress and recovery of the patient? Well, they have a lot to do with it, as we've learned, and of course the system and that you've learned over the years and that you've deployed for many years, you've already had the proven track record of seeing how all that comes together within your system and your traction devices. Very good. Well, thanks for being with us, Dr. Grober. It's been great to visit with you about traction and about what are the best devices to be thinking about. And so with that, I want to thank everybody for listening.